when we say nephrotic syndrome, basically we are talking about a clinical condition where there is a proteinuria, where the urine is leaking out protein. And when we say proteinuria, it has to be a heavy proteinuria. When we say heavy proteinuria, we mean at least the child should be able bringing out 3.5 grams of protein if we are timing it over 24 hours, or 40 milligram of urine per body surface area. Hypoalbuminemia, where the albumin should be less than 2.5 grams. There is an associated edema, and when we talk about the edema, this is a gross edema which is present, and hyperlipidemia. So these are the four things which are to be present when we say the child is having a nephrotic syndrome. Now, when we talk about this, as we have seen that the entire thrust of this nephrotic syndrome revolves around proteinuria. So let us just look at this proteinuria in little bit more in detail. So when we are talking about the proteinuria, we are talking about the heavy proteinuria, otherwise called as a nephrotic range. Now, the nephrotic range of proteinuria is defined as the proteinuria where if you do an early morning urine and you do a protein dipstick, you will see 3 plus or 4 plus of urine, which is shown on the dipstick when you are dipping it in the urine sample. Or if you do a fresh urine spot protein creatinine ratio, then it should be more than 2 milligrams. So this is the ratio that we do in case if we don't time the urine, that is, we don't collect the urine for 24 hours, then you do a fresh protein creatinine ratio. And the third is if case if we do the 24 hours urine, that is, we collect the urine over 24 hours, and then we look at quantify the amount of protein that is being excreted in this in urine, then it should be more than 40 milligrams per meter square. Now, this is this gold standard when you are looking at the proteinuria, that is collecting 24 hours. Then remember, it is little bit cumbersome. At an outpatient, sometimes it is very difficult for the parents to collect it. So we do early morning urine dipstick test or a spot protein creatinine ratio, which also gives us an indication about the proteinuria. Now, a small word here. When we say nephrotic range, we mean that it's a heavy proteinuria. When we say nephrotic range, there is something called as a microalbuminuria, where there is a very slight urine protein which is present in the urine, or it is a nephritic range which is less than the nephrotic range, but it can occur in some of the other diseases like minimum change disease, or FSGS, which is focal sclerotic glomerulonephritis, or membranous proliferative glomerulonephritis. I'll be coming to that. So usually in the commonest type of nephrotic syndrome which we talk about is the minimal change disease, where we see a heavy proteinuria, and this is defined by this nephrotic range. Now, the next thing is the prevalence of the disease. Now, if you look at the protein losing diseases where the protein is coming in the urine, nephrotic syndrome probably is the commonest cause in the children, unlike in adults where there can be so many diseases like diabetes or SLE, etc. In children, it is the nephrotic syndrome which causes the commonest cause of protein leaking in the urine. The incidence of this nephrotic syndrome is around 2.7 per 100,000 cases if you look per year. And if you look at the cumulative prevalence, that is how many cases that we see, then usually over 100,000 cases of children that you see, there will be around 16 children who might develop this protein range of nephrotic syndrome. Now, nephrotic syndrome. And remember, when we are talking about the nephrotic syndrome, the 90%, almost 85 to 90% is because of the minimal change disease. The rest of the type of nephrotic syndrome can occur in the age group, which is either less than 1 year or more than 10 years of age as well. Now, coming to pathophysiology. Now, why this proteinuria occurs? Because the rest of the things, either it is hypoalbuminemia, it is hyperlipidemia, it is usually secondary to losing the proteins. Now, remember, if we go back to our physiology, that there there is a glomerular filtration and from the arterioles to venules. And this filtration, there is a barrier which prevents the protein from leaking out from the glomeruli, that is the Bowman's capsule, to the glomerulus tubules. And this barrier is made of three layers. The first layer is your, of course, a fenestrated endothelium, which is on the side of the blood vessels from where the proteins might leak out. The second layer is called as the glomerular basement membrane. Now, this is the negatively charged membrane which actually repels the albumin or the proteins from going out towards the tubular side from the glomeruli. And the third is called as the visceral glomerular epithelium, which is also known as podocytes. Now, this is the primary site of the event which occurs in the nephrotic syndrome. So, here these podocytes will have the foot processes which acts as a sieve which prevents the proteins from leaking out from the glomeruli to the tubular side. So these three layers, they prevent the proteins from leaking out from the Bowman's capsule towards the tubules. So they do come out in the Bowman's capsule, but usually normally it gets absorbed towards the venular side. Now, what happens in the nephrotic syndrome? In the nephrotic syndrome, this filtration process is disturbed. So the fenestrated endothelium actually enlarges, and there is a little bit more gap between these fenestrations, and this allows the protein to leak out from the blood vessels to the glomerular membrane. And second, what happens is the podocytes or the glomerular basement membrane, they get defective and they do not prevent the proteins from staying back. The negative charge comes down, the foot processes, they get eroded and they become small or effaced, and this will allow the proteins to go down. Now, why this happens is usually not known, and that is why in the commonest cause where there is no other process seen except for the effacement of the foot processes, which is called as a minimal change disease, it was considered that it is idiopathic. But nowadays, with a lot of recent studies and the genetic studies which have been done, now they are implicating this T cells in damage of the podocytes, especially in the case of minimum change disease or focal segmental glomerulosclerosis, where the children do not respond, especially to the steroids. So there is some genetic predisposition which is associated with T cell mediated or disease process which causes these podocytes to get effaced.